Good afternoon, everybody. My name's Claire Parker. I'm a senior lecturer in midwifery at Anglia Ruskin University, and it's an absolute honour to be invited to talk to you today on devising personalised care plans. It looks like an absolutely fantastic day, and I'm really sorry that I can't be with you in person. I'm actually going to be teaching on the day of the conference, but I'd like to share some case studies with you today, which might give you some examples of how I'll use my experience in my previous post as consultant midwife to devise personalised care plans for women with particular needs and preferences. So with some background, a few weeks back, I took on the role of senior lecturer, and prior to that, I was a consultant midwife at a large teaching hospital in the east of England. And in those years working as consultant midwife, I supported hundreds of women to formulate birth plans. Prior to that, I was a matron and a ward manager as well. And I suppose as such, that's made me extremely passionate about the promotion and support of women's choice, the protection of women's reproductive rights, and the provision of respectful maternity care. So I'd like to start with Zahra's story. Zahra is a lady who presented herself to me at 16 weeks. She's self-referred actually to me at Birth Choices Clinic at 16 weeks, having previously been through Birth Choices Clinic in a previous pregnancy. And she was a low-risk booking, so she had no comorbidities whatsoever. She was between 30 and 40 years of age. And as such, she was under midwife-led care with her community team, which were actually out of area across the border. She did, however, have a mental health history of obsessive compulsive disorder that was quite severe, actually, and moderate anxiety. She was also being seen by the Wellbeing Clinic, which is our obstetrician who specialises in mental health conditions in pregnancy and providing additional support in that respect. And in addition to this, she had a needle phobia and she had a fear of pain as well, that I wouldn't say was tocophobia, but obviously very much affected how she was viewing this upcoming labour and birth experience. The fear of pain affected her in the sense that she was very reluctant to go to the dentist and undertake smear tests, for example. Regarding her obstetric history, she had a baby previously, some years back. She'd had a spontaneous vertex delivery following an input from consultant midwife, my predecessor, who made a plan for Zahra to have an early epidural enabled to help her cope with the pain of labour. She was very keen for a repeat of the above experience that she'd had, excuse me, with her first child. She found it such a positive, such an empowering experience. She was looking forward to hopefully having exactly the same again this time around with this pregnancy. So throughout the course of the discussions, and we had several discussions, so most of the time in Birth Choices Clinic, I would speak to people on one occasion. On this occasion with Zahra, actually, we had very regular consultations scheduled, and in keeping with her OCD, they had to be on a particular day of the week at a particular time. And during excuse me, during these consultations, Zahra was able to share with me her preferences, her fears, address any concerns she had, and I was able to then share my opinions about her preferences, offer some clinical advice based on my experience and knowing the services that we had to offer at the trust that she was booked with ourselves. So of the preferences, the most important one for Zahra is that she wanted to avoid surgical birth. She was adamant that she didn't want to have a cesarean. She didn't want to have that extended length of stay that comes from cesarean birth. She ideally wanted an early discharge home. My thinking on this was that actually she was very well suited to a cesarean section, in the sense that, as those of you who've supported Birth Choices clinics in the past will appreciate, that many women who have an element of OCD or anxiety in their pregnancy are very well suited to elective cesarean section, because these women are looking for the most predictable birth outcome. Unfortunately, on this occasion, she was not keen on that idea at all. She wanted to avoid cesarean section, and of course she had no clinical indication for a cesarean section either. In light of her previous birth, which actually happened to be a very rapid labour and birth that she had previously, I suggested that she consider a home birth. She also didn't want to have a home birth, in the sense that she wanted to make use of all the services that we had on the obstetric unit, such as the anaesthetist, and have that early epidural that she'd mentioned to me. Regarding the pain, it's always very difficult to promise people that they're going to have an epidural, and I certainly would never do that with anybody, would never guarantee that they weren't going to feel any pain, but we were hopefully going to put a plan in place for her that would enable her to feel as little pain as possible and to have that early epidural as soon as she was able to. She also had a particular preference for the most senior anaesthetist to be with her. And I think that's regarding her needle phobia. Obviously, she wanted to make sure that there was only one attempt at IV access that was sought, and to have that senior anaesthetist that was present who would ensure that her epidural was as effective as possible. Obviously, my concern on that front is that anaesthetists' presence can be very unpredictable. We tend to have 2 anaesthetists present at any one time at that trust, and you can never predict, obviously, that they're going to be available as and when you need them. And I did make this very clear to Zahra, who, of course, understood that this was a grave concern of hers throughout the pregnancy. She was also very confident and very keen to avoid an assisted birth. She was, again, coupled with her fear of pain and the extended length of stay that she was hoping to avoid, she was very keen to avoid birth assisted by forceps or Von-2s. And of course, in the background, I knew that even by a small degree, I have that knowledge that an epidural anesthesia can, of course, slightly increase the chance of assisted birth. However, I was confident that that wouldn't be the case with Zahra, having had a vaginal birth previously. She also had a particular, a particular preference for a side room. And this was related to her OCD and the fact that when she was becoming panicky, when her OCD was flaring up, she didn't want that to be visible to anybody else. So she was absolutely adamant that she wanted to have a side room throughout the experience. And of course, we're talking about a context in which we were dealing with COVID cases at the time. And at that trust, we didn't have any private rooms that could be booked in advance. So again, it was very difficult for me to be able to promise a side room for Zahra. So Zahra's plan, it evolved over time, as I've said. We had several consultations throughout the pregnancy, and it was a relationship that was built on trust. Zahra trusted me to listen to her fears and concerns, to take her very seriously, and I was able to then share my concerns with her and offer her all the possible solutions that we could formulate that might address her particular preferences. Throughout our many consultations, Zahra had many what ifs that would come up very regularly, such as what if the anaesthetist isn't available? What if they can't site IV access on the first attempt? She didn't think she'd be able to cope with a second attempt at IV access. And over time, we did reach a final decision by around 32 weeks of pregnancy. And that was that she was going to be booked in for an induction of labour, thereby taking away that unpredictability in the sense that she would know when she would be presenting at hospital. She also was going to be invited into the obstetric unit, where she would then get that side room, and therefore she wouldn't have to have her induction of labour on the antenatal ward where she would be sharing a bay. She would actually be having the induction of labour in her own room on the obstetric unit where the anaesthetists were going to be, and hopefully have that early discharge from that same room. Of course, there was that plan for the early epidural and that early discharge home. Throughout the process, I was very keen to maintain that we took a very multidisciplinary team approach. Obviously, with Zahra being a low-risk booking and wanting to request interventions, I was then very keen to involve the obstetrician and anaesthetist wherever possible. And I think it's interesting how when we talk about women who request care outside of guidance, we often think about women who have several risk factors who request midwife-led care, often in midwife-led settings. But of course, we have many women also that request care outside of guidance in the sense that they have no clinical risk factors, but they still would like to request interventions that may pose additional risks to themselves or the baby. So in this circumstance, I was very keen to involve the full team wherever possible. So we involved the obstetrician. And as I mentioned at the beginning, Zahra was already under the wellbeing clinic where she was being supported regarding her anxiety and her OCD. And that consultant obstetrician was very supportive of Zahra and her preference to have an induction of labour, and agreed that that induction of labour could be booked, and also agreed for that induction of labour to be booked early, and it was eventually booked in the 37th week of pregnancy. The consultant anaesthetist, I approached her to actually speak with Zahra over the telephone on 2 or 3 occasions to address Zahra's concerns, most of which did involve the access to an epidural and a senior anaesthetist, and discussing IV access and use of tools such as using Emla cream prior to arriving on the hospital. And she was able to, the anaesthetist herself was able to inform the rest of the team so that in advance of that day, the full team would be aware of Sarah's preferences, so that when they cared for Sarah, they were very familiar with her case, and Sarah was very keen. She didn't want to have to repeat her preferences and her background to everybody. I also involved the induction of labour coordinator midwife. We were very fortunate. We had a fantastic induction of labour coordinator midwife role. This midwife would arrange Zoom classes for people that couldn't access the hospital due to COVID restrictions. And this midwife actually spoke with Sarah on several occasions and was really able to speak to Sarah in a very detailed way about what the induction of labour would involve. And also I was very conscious, as was the induction of labour coordinator midwife, to emphasise to Sarah that we may not be able to invite her in on that particular day, obviously with capacity being very high at the time with inductions of labour. I wanted Sarah to be aware that actually she may be delayed by a day or two, because obviously she had no clinical indication for that induction of labour, and she was completely understanding of that. And also the clinical lead midwives on the obstetric unit, so the coordinators of each shift on the obstetric unit, nearer the induction of labour date, I spoke to all of them and sent all Sarah's details across to them. So again, similar to the anaesthetic team, when Sarah would present on the day, that they would be fully briefed on Sarah's background and her fears and preferences, and would be better aware of how to support Sarah on the day. So Ellie's birth. Her induction of labour was actually delayed by 1 day. Again, that was because of acuity on the day that she was due to come in. She was fully briefed on that beforehand. It wasn't a surprise to her. Of course, it wasn't her preference, but she was invited in the following day. And her induction of labour did commence on delivery unit in her own room. IV access was cited by a senior anaesthetist who knew about Sarah's case ahead of the day. And actually on that day, I was the maternity bleep holder, and I was present on the obstetric unit myself, and I was in the room holding Sarah's hand while she had that IV access cited. And I think actually she laughed her way through the whole process. It certainly wasn't as bad as she feared. The epidural was cited prior to us breaking her waters, so prior to that ARM, and certainly before the onset of regular contractions itself. And Sarah went on to give birth in the night and had a non-assisted vaginal birth. And again, I was present on the obstetric unit when she birthed her baby. As manager of the day that day, I had been called back into work overnight and was delighted to be around to support the midwives that were caring for Sarah during the night. She did have an extended postnatal stay of 4 days, and I know that she was hoping to get home that same day. But as we'd explained to her, one of the risks of the induction of labour being so early in the 37th week is that the risk of complications with the baby postnatally, such as the increased risk of jaundice and feeding support. Luckily for Sarah, she did have access to a side room on the postnatal ward, which she made use of and was delighted about. Sarah gave the whole team feedback, and she said, "Thank you for making sure my birth plan was perfect. You made me feel safe, understood and cared for. Your support enabled me to have a positive birth experience." I just want to very briefly give you a second case study, which is a lady called Carly, who had a very, very similar background, although ended up with a slightly different plan. Her history was similar in the sense that she'd had a previous vaginal birth that on paper looked very straightforward to us as clinicians. However, to Carly, it was a particularly traumatic birth, and she'd waited several years before considering becoming pregnant again. Again, we had input from the full MDT, and also we had a maternal emotional wellbeing midwife support Carly, as she also had a background of anxiety and this secondary tocophobia that she was trying to manage as well. And Carly, we actually had a plan for a booked induction of labour and caesarean section, because throughout our consultations, Carly couldn't decide whether she would take the risk of going into labour before an induction of labour or whether she'd have an effective epidural. So actually opted to have both an induction of labour and the caesarean section booked. And in the end, 3 days before her booked caesarean section, we met face-to-face on site at the hospital, and she said to me that she wanted to cancel her induction of labour and go straight for the surgical birth option, which she had been hoping to avoid, but felt it was the right choice for her. And I just think her feedback is absolutely fantastic. I've been able to bond with my daughter instantly, something that took a backseat to trauma and recovery last time, and I'll never stop being grateful for that. The experience has been so different this time, and I owe it all to the team for supporting and informing my choice. So I'm very conscious that I'm probably reaching my limit of 15 minutes now, but I hope it's been useful to share some case studies with you today for people that are requesting care outside of guidance and people that are requesting interventions that are non-clinically indicated based on their personal preferences and choice. I'd just like to end by highlighting some of the MDT team working process that was so crucial to making both these women's plans come to fruition. And that was, I believe, it keeping both Carly and Sarah at the heart of everything we did regarding decision making and fully informing these women of their full range of options and letting them be the final decision makers in their care. So obviously that began with myself as consultant midwife, who Sarah contacted in the first instance. I then got in contact with the obstetrician who was supporting her, the anaesthetist, and her whole team were brought into the equation as well to take any queries that both women had and share information with their team. Also, the introduction of the induction of labour coordinator into the process really supported Sarah, I know, the first case that I presented. And then, of course, the obstetric unit midwife leads. These are the midwives that are going to be coordinating the whole of the shift where these women are going to be presenting and having their care episodes. So they need to be fully briefed on the processes and the preferences involved. And to have some background, because I'm sure many of you who've got experience in running birth choices clinics are aware that such women are really hesitant at repeating their story and their background to many practitioners as possible. So I believe we were so successful in giving some really personalised care to these women because we did work as a team very successfully in both cases. Thank you for your attention during these case studies. I'd love to take any questions or feedback that you have on these today or in the future. So if you want to, please do contact me at the email address below. And again, thank you very much for listening today. Have a great day.